I'm really pleased to introduce two very important speakers who have great expertise on a topic of great interest. Dr. Supaksh Gupta is a recent graduate who completed training in pulmonary, critical care, and sleep medicine at the University of Washington. His research expertise involves exploring the impacts of climate change on individuals with COPD, and currently he practices at the VA Puget Sound with a focus on caring for individuals with ALS. Dr. Paula Carvalho graduated from the University of Washington School of Medicine in 1984. She works in Boise, Idaho, and specializes in pulmonary, internal medicine, critical care medicine, sleep medicine, and hospice and palliative medicine. Dr. Carvalho is affiliated with the Boise VA Medical Center, and welcome to you both, and feel free to take it away, Dr. Gupta.
Great. Thank you so much for that introduction. It's really a privilege to be here with all of you presenting today. So our topic, we'll be talking about pulmonary infections in the older adult. If we could go to the next slide. Neither myself nor Dr. Carvalho have any relevant financial disclosures to report for this presentation. So we split this talk up into two sections. First, we'll talk about bacterial pulmonary infections, and then next, after I complete that section, Dr. Carvalho will talk about viral infections. So the learning objectives for this talk that we hope you will take away from this is, one, to identify the most common causes of bacterial pneumonia. Two, we want to talk about the symptoms to look out for pneumonia in the elderly, and we'll see how those may be different than some of the symptoms that we typically think of. And then finally, I'm going to spend a lot of time talking about the most recent ATS and IDCA guidelines about what are appropriate antibiotic selection in this patient population, as well as vaccine recommendations, which is extremely important.
Sorry, I'm trying to advance, and hopefully on one of these clicks it'll go. Barb, is something frozen at your end?
I'm not seeing anything frozen.
We were advancing okay, but now it seems to not go anywhere. So how about if I stop sharing and restart? Okay. Sorry about that, Supaksh.
Sure. Oh, no problem.
Okay, there we go.
Great, thank you. So first, we're going to talk about the epidemiology of community-acquired pneumonia. And so really the case I want to make here is that this is a really important and relevant topic to all of us who are taking care of patients over the age of 65. So the annual incidence of community-acquired pneumonia for all comers is about 248 cases per 100,000 adults. But that increases significantly as we look at older populations. So if you're looking at patients between the age of 65 to 79, that increases, over twofold. And then for patients over the age of 80, that increases to nearly 16,000 patients per 100,000 adults. And so community-acquired pneumonia, it's the most common reason for hospitalization, or third most common reason for hospitalization in patients over the age of 65. And over half of the patients that are hospitalized for pneumonia are actually in this age group of over the age of 65. If we go to the next slide.
Dylan, I may have to have you control on your end. For some reason, mine is just not advancing.
Can you click on that PowerPoint and then do the arrow?
Okay, we're at the next one. We're just going to see if this continues. And sorry about the inability of the advancement here.
No problem. So this is another graph kind of showing what I just talked about. So this is a different study. This is actually looking at adults specifically in the United States. And so at the y-axis, you have rate per 100,000. And on the x-axis, you have 3 different age groups: 18 to 49, 50 to 64, and 65 plus, which is the population that we care about. And then the bars in between kind of show, the black bar is healthy adults, and you can see is that as you have more comorbidities, the incidence of community-acquired pneumonia increases, and then unsurprisingly, if you're immunocompromised, that increases more dramatically. And so you can see that in each of those categories, for individuals over the age of 65, the incidence increases if you're healthy or have comorbidities, and particularly if you're immunosuppressed. And so what is the mortality in community-acquired pneumonia? So hospitalized patients, it actually ranges from 10 to 25%. And there was a study that was done in Spain looking at 30-day mortality. And in this study, they found that it increases significantly as we get older. So in patients that were 65 to 74, it was about 7%. That nearly doubled to almost 14% in patients 75 to 84. And then it reached close to the upper bound of that 25% in individuals that are over 85. So you can see that the mortality increases significantly as we get older. And so why are older individuals having pneumonia more frequently, and why are they having more severe infections and increased risk for mortality? There's really a number of different reasons. So one is that there's decreased efficiency of nasal mucociliary clearance. So we have cilia in our nasal passages, in our lungs, and these are lots of small hairs that are constantly beating, and they're designed to kind of get debris or microbes out of our lungs. And so that becomes less efficient as we get older. So you're more likely to have things kind of set up shop or blossom into pneumonia. The second reason is that lung function declines as we age. So lung function for all of us really peaks around, in our 20s and 30s. And then every year after that, it slowly declines. And so if you have worse lung function, you're going to be less likely to sort of combat that infection and recover from that infection. And lung function actually declines faster in individuals that continue to smoke or have lung disease like COPD. Another really important reason is immunosenescence. And so that's basically just a fancy word for saying that our immune system becomes less efficient, less effective as we age. And so every aspect of the immune system, so the humoral immunity, cell-mediated immunity, all of these things get worse as we age. And we'll see some of the downstream effects that relates to in the presentation of pneumonia in elderly individuals. Another reason is that as we age, we're more likely to have heart disease, kidney disease, diabetes. And we saw on that prior slide that if you have more comorbidities, you're more likely to, you're going to have a higher incidence of pneumonia, and then you're also going to be more likely to have a worse outcome from pneumonia. A very, very important risk factor is silent aspiration, oropharyngeal dysphagia, and poor dental health. If you have poor dental health, that is basically a nidus for bacteria to kind of set up shop. And you're going to have some degree of aspiration of those bacteria into your lungs. And so oral health is really important. Screening for any oropharyngeal dysphagia and trying to manage that as best you can is very important. And finally, declining physical activity. We tend to become, we could become weaker, our muscles become weaker. Being bedridden is a very strong independent risk factor for developing pneumonia. And so all of these things play a really important role in the higher incidence of pneumonia and the higher mortality that we see associated with that. So this is a slide kind of showing what are the different pathogens that are there in adults. And Paula, if you could advance to the next slide. So the pneumococcus and Haemophilus are still the two most common bacteria that are implicated in pneumonia in adults. And so this plays a really big role, as we'll see, in what the antibiotic selection for individuals is. Despite the fact that we have vaccines, different pneumonia vaccines, there's over 90 different serotypes of pneumococcus. And so even though we have vaccines for the most virulent strains, there's still a lot of strains out there that we don't have vaccines for. And then I just want to highlight other bacteria like Legionella, Mycoplasma, Chlamydia. So these are kind of considered some of the atypical infections that cause pneumonia. And those are important because these tend to be resistant to the antibiotics that we use for pneumococcus and Haemophilus. And that also is important in terms of antibiotic selection, as we'll see later. And Paula, if you could advance to the next slide, please. So the symptoms in the elderly is actually very different than in younger individuals. And so if you look at the column to the very right, all of these are looking at different symptom profiles in adults over the age of 65, and in the first column, adults over the age of 80. And so the big takeaway, so you can see for cough and fever, nearly 40% of patients did not have cough, did not have fever. And you can see that altered mental status was present in nearly half of patients. And so when patients present with pneumonia at the age of over 65, it's very common for them not to have the typical features that we think of with pneumonia, like cough, coughing up purulent sputum, fevers. And again, a big part of that goes back to the immunosenescence we talked about. So if your immune system is not as effective or efficient, you may not mount that immune response to develop a fever. And so you really need to have a high index of suspicion for these patients. And so they may present just with altered mental status, functional decline, incontinence. And so you need to really have a high index of suspicion because missing this, it's very frequently missed in this population, or you may diagnose it much later on. And as we know, time to antibiotics and infection is really important. And so overall, patients over the age of 65 tend to present less frequently with the typical symptoms that we think of with pneumonia. So I'm going to really focus in on the new ATS-IDSA guidelines that came in 2019 regarding appropriate antibiotic selection and other decision-making surrounding bacterial pneumonia. And so why do we care about guidelines? So this was a really nice study that was done looking at adults from all over the world, actually, including the United States. And so there's two graphs that I've taken from that paper. And so the y-axis is probability. On the first graph, there's length of stay. And the solid black line is the adherent treatment. And so adherent treatment here is appropriate antibiotic selection adherent to the appropriate IDSA guidelines. And so you can see that there's about a 2-day difference. They found a 2-day difference in length of stay. So patients that were prescribed appropriate antibiotics were more likely to leave the hospital earlier. And in the second graph, even more importantly, either over or under treatment led to a higher degree of mortality, and appropriate antibiotic selection led to nearly an 8% decrease in mortality. So I just want to point out that, guidelines are there for a reason, and it's important to know what the guidelines are, because appropriate, following of the guidelines really can make a big difference. So I have a question here. So we have an elderly 75-year-old man. We'll call him Abe. He has a history of diabetes, high blood pressure. He comes into the emergency department. He's altered. He has shaking chills. You obtain a chest x-ray and it shows a lobar infiltrate. He doesn't have a fever. His heart rate is 86. His respiratory rate is 32 and his blood pressure is 145/93. So which of the following would you recommend next? A, no treatment needed. B, we can treat this patient for pneumonia as an outpatient. C, we can treat this patient for pneumonia and we think he needs to be admitted. Or D, you need more information to make a decision. So if people want to put into the chat what they think is the correct answer, and I'll give people a few seconds to respond.
Looks like you're getting an overwhelming choice of D.
Yeah, great. Paula, if you want to advance to the next slide. So a lot of people said D. I think getting more information is never the wrong answer. It's always good to get more information, but I would argue, and we can see why I made the answer inpatient admission for this patient. So there's a number of scoring systems that are out there, for pneumonia. And I'm going to talk about two of the most common ones. And I think this is probably the one that is most relevant to people in this audience. And that's the CURB-65 score. So it's a pretty simple system. C is confusion or altered mental status. You could use, are they alert and oriented to person, place, and time to diagnose that. The second point is they would get 1 point for confusion, 1 point for an elevated BUN over 20, 1 point for a respiratory rate over 30. And so our patient was confused and had a respiratory rate over 30. And then 1 point for blood pressure, for low blood pressure, systolics less than 90 or diastolics less than 60. And then an age over 65. And so I just want to highlight that every patient over the age of 65 that we're talking about in this conference is going to get automatically 1 point. And so our patient would have 3 points, 1 for age, 1 for respiratory rate, 1 for confusion. And so it's important to know that, these scoring systems weren't developed to figure out triage. They really were just created for prognostication and mortality prognostication at 30 days. And so our patient kind of falls into the bucket on the right where they have a high risk of mortality, and you should really probably manage this patient inpatient. These are not substitutes for clinical decision making, but it's just another decision point to help you make your decision. And if we go to the next slide. So this is the Pneumonia Severity Index score, or PSI. It's also known as the PORT score. This is a much more complicated and cumbersome system to use. And again, designed primarily for prognostication, but can be used to help you decide, does this patient need to be treated outpatient or inpatient? And so if you look at the first column under demographics, you get 1 point per year. And so any patient who's 65 is automatically going to fall into the risk class 2 or above. And so if they have comorbidities, they're going to get somewhere between 10 to 30 points. If there's vital sign abnormalities, they're going to get between 15 to 20 points. Any additional labs that are abnormal, between 10 to 30 points. You can see that it's very easy if they have any vital sign abnormalities, lab abnormalities, comorbidities, to quickly jump into that risk class 3 or above, at which point you should consider admitting that patient inpatient for management. So this is taken directly from the 2019 IDSA ATS guidelines. And so it asks, should a clinical prediction rule for prognosis plus clinical judgment versus clinical judgment alone be used to determine inpatient versus outpatient treatment for adults with community-acquired pneumonia? So they go on to say that clinical judgment, in addition to clinical judgment, we recommend that clinicians use a validated prediction rule for prognosis to determine the need for hospitalization. They go on to say that they recommend the Pneumonia Severity Index score over the CURB-65 score, just because it has, it's because of the additional information that goes in, it's sort of a little bit more accurate. But really, I think none of these tools are a substitute for clinical judgment, but they can just be another really helpful tool to figure out whether that patient needs to be admitted inpatient or outpatient. And another point that I'll make is that, you really need to think about the social situation of the patient. Do they live alone? Do they live with other people? Do they have support? If they decline, can they easily access healthcare? Can they tolerate oral antibiotics? Are they having nausea and vomiting and they can't take any oral intake? So there's a lot of things that obviously go into the decision-making of whether someone should be treated inpatient or outpatient. But I think in the elderly population, if they're having, vital sign abnormalities, lots of comorbidities, I would have a low threshold for potentially treating that patient inpatient. All right, so we have another patient here. We'll call her Agnes. So Agnes is a 68-year-old woman. She has a history of chronic kidney disease. She comes into the ER. She has fevers and a productive cough for a few days. You get a chest x-ray and it shows a pulmonary infiltrate. Her temperature is 98.6. Her heart rate is 65. Her respiratory rate is 18 and her blood pressure is 112/74. So which of the following do you recommend as part of the diagnostic workup? And you can, again, just put in your answers in the chat. A, let's collect urinary antigens for Legionella and pneumococcus. B, let's obtain some sputum cultures. C, blood cultures. D, urine, antigens, and sputum cultures, or E, none of the above? And I'll wait for a few seconds to allow people to put in some answers in the chat.
We're getting some possible B as in boy or D as in dog.
Great.
Oh, and a C.
All right, yeah. So we see a bunch of different answers. I think overwhelmingly looks B and D. And Paul, if you want to advance to the next slide, please. So I will argue that the answer to this, based on the guidelines at least, is none of the above. And we can go to the next slide. So this again is taken from the IDSA 2019 guidelines. So this patient, was elderly, but they didn't have any vital sign abnormalities. I didn't give you any additional information, but based on their CURB 65 score, based on the information we have, it would be 1. And so you could definitely consider treating this patient as an outpatient. And so for outpatients, they do not recommend getting sputum, blood cultures, or urinary antigens. And the reason for this is that you're going to kind of treat this patient empirically, and they're more likely to have, the most common organisms like pneumococcus hermophilus. And so that additional information is unlikely to change your management. And the sputum cultures you obtain, the sensitivity for those for actually getting a causative organism is not very high. At the very bottom, if you have a hospitalized patient for severe pneumonia, that's a situation where they do recommend obtaining pretreatment sputum, blood cultures, urinary antigens. You'll see that they have a conditional recommendation in the middle to not obtain any of those tests, the same as in outpatients. For hospitalized patients, if they have non-severe CAP, they provide some exceptions, which are patients that were empirically treated for MRSA or Pseudomonas or received antibiotics in the last 90 days. I will say that, this is probably something that I don't totally follow or agree with. If I think a patient is being hospitalized for pneumonia, I think these are all reasonable and appropriate things to obtain, but certainly in the outpatient setting, I think it's very reasonable to not obtain any of these things. So they had a branching point there based on severe versus non-severe pneumonia. So how do we define that? So it is a combination of either one major criteria or 3 or more minor criteria to meet for a diagnosis of severe pneumonia. So the major criteria are pretty obvious. I think we would all agree if someone is intubated on ventilation or needs vasopressors to support them, then that would count as severe pneumonia. Minor criteria include the 3 things that we talked about in the CURB score. So confusion, BUN over 20, respiratory rate over 30, and then includes a few other things like low temperature, a lot of infiltrates on the chest x-ray, hypotension, you're having to give them a lot of fluids, low wipe count, or low platelets. All right, so we're back to Agnes. We said, okay, we're going to treat her as an outpatient. Which of these outpatient regimens would be most appropriate for this patient? And again, she's a 68-year-old woman and she has chronic kidney disease. So again, you can put your answers in the chat. So A, let's use amoxicillin. B, azithromycin. C, doxycycline. D, cefpodoxime. Or E, azithromycin and cefpodoxime. So I'll give everyone a few minutes or few moments to type things in.
Looks like we're getting a variety, couple of C's.
Okay, great. So for this patient who you're treating as an outpatient who is 68 and has chronic kidney disease, Paula, do you want to advance to the next slide? I would say that the answer here would be azithromycin and cefpodoxime based on the guidelines. We can go to the next slide. So what do the IDSA guidelines? Again, this is directly from the most recent 2019 guidelines. So for patients without risk factors, you can use monotherapy with either amoxicillin, doxycycline, or macrolide. And primarily you would be using azithromycin most commonly, but clarithromycin is also an option. And so they define risk factors very, very broadly. So things like alcoholism, diabetes, cancer, or any chronic heart, lung, liver, or kidney disease. So since our patient had kidney disease, I was trying to point to you that they may have some risk factors. So that's in the outpatient setting. Do you want to go to the prior slide for a moment? So the macrolide has a caveat. So they say that monotherapy with macrolides is fine, but only if the local pneumococcal resistance is less than 25%. Next slide, please. So I went and looked at, many of the regions that many of you may be coming from, and what is the resistance to pneumococcus in your area. So here locally in Seattle at Harborview, the local resistance is 28%, so above that 25% number that they gave. I found some data in Anchorage that said the pneumococcal resistance to macrolides there is lower at 11%, so monotherapy there may be reasonable. And in Billings, it was pretty high at 39%. In Idaho, that I found some information at 26%. Again, the most important thing is if your local hospital has an antibiogram, I would use that as your branching decision point. But in a lot of regions that we're coming from, we're seeing pretty high rates of resistance to macrolides and pneumococcus. And so this is where I would argue that our patient fell, Agnes. So she had risk factors of chronic kidney disease. And so here, you're going to treat them a little bit more broadly. And there's two reasons. One is that, the risk of being wrong is higher in this patient population. They have comorbidities and the risk of more severe disease or worse outcomes is higher. And so you're going to treat them more broadly. And additionally, these patient populations have been found to have more resistant organisms. So appropriate treatments here would be beta-lactam, like amoxiclav or cefpodoxime, plus a macrolide or such as azithromycin or doxycycline. Or you could use monotherapy with a fluoroquinolone in the situation as well. All right, so we're back to Abe. We admitted him into the hospital. We're treating him for pneumonia. What antibiotics do you recommend starting for severe pneumonia? So we said that we had confusion, he had elevated respiratory rate, and let's say he met one more criteria, and we said that he has severe pneumonia. He has no risk factors for MRSA or Pseudomonas. What antibiotics would be appropriate? And again, you can type your answers into the chat. A, vancomycin and cefepime. B, ceftriaxone and azithromycin. C, ceftriaxone. D, azithromycin, or E, levofloxacin.
We're getting some A's.
Okay.
And a B.
All right. Paul, if you want to advance to the next slide. So I'll argue based on the guidelines that here I would say that the correct answer would be ceftriaxone and azithromycin, and let's take a look at why that is. So based on the IDSA guidelines for non-severe community-acquired pneumonia, and this is patients without risk factors for Pseudomonas or MRSA, they recommend treating with a beta-lactam, so an IV beta-lactam plus a macrolide, or monotherapy with a respiratory fluoroquinolone. And the next slide, please. And then for severe pneumonia, you can use the same thing that you used in non-severe, so beta-lactam plus a macrolide. The difference here is that they do not recommend monotherapy with a fluoroquinolone. And so if you're going to use a fluoroquinolone, you should also use a beta-lactam. And so since our patient had severe pneumonia, I would argue that a beta-lactam, such as ceftriaxone or amsulbactam, plus a macrolide would be appropriate. All right, so we're back to Agnes. She got treated for pneumonia. She's doing great. You're taking a look at her vaccinations, and you note that she got the pneumococcal conjugate vaccine, PCV20, 1 year ago. What additional vaccines do you recommend right now? So go ahead and type your answers into the chat. A, we think that this patient needs pneumococcal polysaccharide, which also known as Pneumovax, PCV13, PCV15. It's been 1 year since she got PCV20, so she needs that again, or E, no additional vaccines necessary.
You're getting a lot of A's and a couple of D's.
Okay, great. Paula, if you want to advance to the next slide, please. So here, the correct answer is actually E, no additional vaccines necessary. Let's take a look at why that is. So before I jump into that, I just want to talk about vaccine efficacy. So Pneumovax, or the pneumococcal polysaccharide vaccine, has been shown to decrease the incidence of CAP by about 28% in adults over the age of 65. I will say that this data is kind of all over the place. There's some meta-analyses that show it doesn't really actually decrease the incidence of pneumonia at all, or less than this. It's really most effective at reducing the rate of invasive pneumococcal disease, so bacteremia or meningitis due to it. The pneumococcal conjugate vaccine, on the other hand, is much more effective for reducing the incidence of pneumonia, and has been shown the PCV13 has been shown to reduce the incidence of pneumonia by 45%. And there was an interesting study that came out recently that looked at adults between the ages of 65 to 70 during the COVID pandemic, and the appropriate rate of vaccination in that population was actually only 61%. So definitely something we could be doing a better job about. So what are the current CDC guidelines for adults over the age of 65? So the PCV20 is a relatively newer vaccine, and it has really simplified things. And so I strongly recommend this in patients because it's so much easier. If they're over the age of 65, they get PCV20 and then you're done. And just as an aside, what do these numbers mean? PCV13, 15, that's how many serotypes that they're actually vaccinating that patient against. So PCV20 is vaccinating against 20 different serotypes. If you opt to go with PCV15, then you do want to give that patient Pneumovax 1 year later. If you start with Pneumovax, then you want to give either PCV15 or Prevnar 20 1 year later. They no longer recommend PCV13 just because there are sort of vaccinations available that are effective against more serotypes, so they're no longer recommending using PCV13. If you have a patient that's gotten PCV13 before and Pneumovax after the age of 65, you can talk to them and you can consider giving them PCV20 again. The patient population I would think about this are patients that you think are at high risk of disease, or potentially patients with comorbidities like lung disease, which put patients at higher risk of getting pneumonia and more severe pneumonia. So I think this is a really big takeaway slide that I hope everyone here learned something from. So what are the non-pharmacologic things that we can do for risk reduction? So I mentioned that poor oral care is a really strong risk factor for getting pneumonia. So oral care is extremely, extremely important. You want to make sure that that patient is visiting with the dentist routinely if they have any infections or diseased teeth that need to be removed to get those out. That's going to reduce the bacteremic burden in their oropharynx. That also can actually just getting routine oral care and appropriate oral care can actually improve the swallow as well. We talked about, being bedridden is a strong risk factor for disease. And so regular physical activity is really, really important. It can slow down functional decline. Physical activity is actually the most effective therapy for effective airway clearance. So, walking regularly, exercising can really help get some of that phlegm out of your lungs. I cited a study that showed 61% of adults over the age of 65 were not appropriately vaccinated. So this is something that all of us can take a look at, even if you're not ordering the vaccines or administering them. You can take a look at the vaccines. If they're not up to date, you can educate the patient about what they should get and why it's important. And then again, aspiration is really a huge one. And so screening patients for oropharyngeal dysphagia, if you're concerned about things, referring them to speech therapy. They can teach them exercises to reduce aspiration. Patient compliance with medications is important. We talked about more comorbidities means more likely to develop pneumonia. And so appropriate management of those diseases with their medications is important. If a patient has lung disease, appropriate compliance with their inhalers, as well as the importance of appropriately using those inhalers so they're actually getting that medication delivered. And then substance use is a really big one, especially tobacco. So I think all of us can, talk to patients who are still smoking cigarettes about the importance of quitting. And then alcohol is also a strong risk factor for developing pneumonia. And malnutrition is really strongly associated with developing pneumonia and more severe outcomes. And so screening patients for this and referring them to nutritionists or educating them about this is important. So what are some of the takeaways? Just to recap, so strep pneumo is still the most common cause of community-acquired pneumonia, so make sure that their vaccines are up to date. Again, CAP may present differently in the adults, so you need to have a high index of suspicion, look for things like altered mental status or functional decline. Have a low threshold for inpatient admission. Again, with that CURB 65 score, we saw even just with the age of over 65 and one more risk factor, you should consider inpatient admission in those patients, especially if they have lab or vital sign abnormalities. And then all of the things that I talked about in the prior slide. So dental care, making sure vaccines are up to date, making sure they're using their medications, screening for dysphagia. So that's the end for my portion. So if you have questions, feel free to type them into the chat, and then we will be sure to get to as many as we can after Dr. Carvalho's section is done. Thanks so much.
Hi, everybody. And Supaksh, that was outstanding. There's a lot of new information there. It all makes sense. So I really appreciate the organized, point by point way that you presented this. I'm going to present viral infections, which are kind of onerous, and I stole Grandpa Simpson here from Supaksh. And this is actually.
Can you turn on your video?
I will, and hopefully I don't freeze. So if my video freezes, let me know. Okay. Thanks. So this is actually a patient that we have in our ICU right now. 75 years old, presents with fever, cough, increased shortness of breath for 48 hours. He lives over in our assisted living facility. We've had a lot of residents with similar symptoms. They've tested positive for the trifecta of COVID, influenza A, or RSV. So we'll keep that in mind. We're not going to ask any questions now because I'll tell you what happened to him afterwards. So this is an update, and with these viral talks, you almost have to do it the night before because the CDC reports information frequently, but not every day. So I've tried to get the most recent epidemiology that we've got available. So we're going to review the epidemiology, transmission, and then the review of the treatments and vaccines. So we're going to start with influenza. So right now, as of the 12th of this month, Idaho is not doing very well. Washington is doing better, and Oregon is doing even better, as you can see over here in this map with high numbers, moderate numbers, and low numbers. So these are some of the numbers that we've had. We have 14 to 26 million flu illnesses, a lot of medical visits, lots of hospitalizations, and quite a few deaths. If you compare the data for this year with the data for the period of time where the numbers really went down because everybody was masking because of COVID, you can see a big difference here. 14 to 26 million illnesses now, and 2.4 to 4 million illnesses back in 2021 through 2022. That's a big difference. But look at this. We have here on the bottom panel, we've got the data about the numbers in 2018, 2019, which were 9.6 million. And now we're comparing with what we have now, 14 to 26 million. This is a bit scary. And I saw a scary face go by here on the screen just a second ago. I agree. These numbers are actually quite disturbing. And I'm going to tell you why in just a second. So we're going to talk about the anatomy and epidemiology of influenza. So there's 4 types. D, C, B is human infection only. The genetic and antigenic properties of influenza B change quite a bit more slowly than influenza A. So influenza A is the one that really is on the move, and it's responsible for regular outbreaks. including all these pandemics that we've had, dating back to the first known one in 1918. Flu A was responsible for this horrendous Spanish flu that killed a lot of people, and nobody knew what caused this. And it really wasn't figured out until about 1930 in animals and 1933 in humans. So it's got an anatomy that actually really is conducive for its function. So this is an RNA virus. It's wrapped in a lipid bilayer, and then we've got these little membrane proteins, kind of like cloves in an orange. And we've got the H and N proteins, and they're encased by this lipid bilayer with segments of RNA inside the organism. Excuse me. And each of the 8 molecules is associated with a ton of proteins of this, copies of a nucleoprotein. We have H1, H2, and H3 in human viruses, and these really have a huge affinity for respiratory epithelial cells, and they bind very, very tightly, which is why we get such horrible respiratory disease with this. There's 2 main subtypes of neuraminidase, which is N1 and N2. We've got other subtypes of both H and N in animal viruses, but only influenza A causes the global pandemics. Just to review how this thing happens, and this is why I want you to keep in mind these huge numbers that we have in terms of influenza, which is actually really getting downplayed by the CDC at this time. But I once we talk a little bit more about how these occur, you can see that an antigenic drift is a minor change in the H and the N. So we've got the yellow triangle, and then we have here half of the yellow triangle, and then for genetic antigenic drift. For antigenic shift, we've got a complete different type of determinant as compared with the one before. So these are major changes in H and N, and this is what leads to epidemics and pandemics. And this is what's happening now with us. So how do these strains emerge? Well, they have the segmented genome, and they just kind of reassort themselves, and it's kind of the luck of the draw. And there can be also reassortment between animals and humans that can result in pandemic strains. So the pandemics of 1957, 1968, and 2009 were due to animal and avian and human reassortments. And unfortunately, this is what is happening now. When you see the nomenclature of influenza, this is how this works. First, the first letter is the type. It could be an A or a B. The origin. We have here the strain ID that's given by the CDC. We've got the year of isolation, and then we've got the determinant of hemagglutinin and neuraminidase. So this is an H5N1 example. And when we look at pandemics with antigenic drift and antigenic shift, going back all the way to the 1918 pandemic, it was an H1N1. There was a pandemic because we now had complete changes in the H's and the N's. H1N1 to H2N2. So again, a lot of deaths because of the pandemic of 1957. And then we go on to the Hong Kong flu, which is an H3N2, which the age determinant changed. 1976 was swine flu in recruits, and everybody thought this was going to be really horrendous because it went from H3N2 to H1N1. So 2 completely differences from the H and the N determinants. But it wasn't as, it was bad, but it wasn't as bad as some of these other pandemics that they've had. In 1977, this particular H1N1 escaped from a lab in Russia and caused a bit of damage. This was a descendant of the 1918 flu, H1N1, had a lot of similarities. It was being worked on in a viral lab and caused damage. 2009, we might remember that they had closed down the airport in San Francisco, all sorts of problems with travel because of infection. A lot of our veterans, we were very worried about them because we thought, oh my God, we're going to have this huge mortality with our veteran population. Not so much. These guys were fine. They had seen H1N1 in other years, and the ones that were sick were our residents who had not seen this to any degree in their lifetime. So that became a problem. Unfortunately, this is what we have at this point as well. Last year, we had an H3N2. This year, we have an AH1N1. PDM means pandemic strain 2009. So this is very, very similar to the 2009 organism. And this is why we're seeing these very, very high numbers. I'm just getting over a viral infection myself, so excuse the coughing, but it is out there. So now transmission, presentation, and diagnosis. This is, of course, as we all know, it's transmitted by micro droplets, and we have droplet nuclei, and the smaller the particle, the longer it actually can float in the air and infect us. We can also touch things and contaminate ourselves that way as well. The incubation period, the average is about 2 days, and then we shed virus for about 24 hours before symptoms. We continue to shed virus for 24 to 48 hours of illness, and then we shed less and less virus for about 10 days. But in elderly people, those with some comorbidities like obesity, chronic diseases, immunosuppression, these people can actually shed virus for a longer period of time. The serial interval, and that the definition of that is, let's say that dad gets sick, and then the next relative to get sick is going to be somebody else in the family. The interval is generally 3 to 4 days. So in between people, it's about a 3 to 4 day infectivity period. The symptoms are intense. I think we've all had it, some form of flu or another, but terrible headache, fever, chills, your eyes hurt, your muscles hurt, your throat hurts, and it can be really quite acute. And people will say, I got hit by a truck. I was fine this morning, and by this afternoon, I've got rigors, headache, and feel absolutely awful. Fever can be high grade, and the average is about 3 days. Fever, as I'm going to mention in just a second, may not be a feature in the elderly. And this is why we have to be very careful to not miss the diagnosis of viral infections in an afebrile, sick elderly person. Cough is initially quite non-productive, very annoying, and can persist for weeks. Sometimes there's secondary infection with bacterial infection where you can end up getting a lot of purulent sputum. So generally, we're going to have complete recovery in a couple of weeks. But again, the older you are, the longer the recovery might take. And one may have fatigue for several weeks, but what influenza does not do, that COVID does, is it does not give us long influenza. We do not have that. So this is something that is quite a very specific feature of COVID. Now, with immunocompromised patients, either immunocompromised due to age, again, with immunosenescence, like Dr. Gupta mentioned, or chronic immunosuppression from medications, the symptoms may be really kind of minimal. Nasal congestion, lethargy, sometimes altered mental status, just simply a lack of appetite or a cough, and the patient may be entirely afebrile and be a lot sicker than we give the patient credit for. So we have to make sure that we don't expect these elderly or immunocompromised / suppressed patients to be febrile. They can still be quite ill. So the groups at high risk for complications, again, adults greater than or at least 65 years old, patients that are morbidly obese, again, immunosuppressed or immunocompromised. Pregnancy is certainly a risk. Back in 2009, I remember that there were a lot of pregnant women. I know this happened in Seattle because my friends there were telling me about this, where they're ending up on ECMO at one of the hospitals there, and they were tremendously ill. And these were previously quite healthy people that they were pregnant. Same thing happened in the UK where I was at the time. Same thing happened in Australia and New Zealand and pretty much all over the world. Native Americans and Alaskan Natives also are higher risk for complications. And again, of course, long-term or chronic care setting residents. If you've ever seen, this is kind of impressive, if you've ever seen an electromicrograph of influenza effect on the cilia, on the left panel, you see this very nice field of long, tall grasses that whip back and forth. And this is the cilia that help us with our mucociliary clearance in our airways. Then here on the right is a bronchial wall that now has been denuded because it's been infected with a viral disease. These cilia look like somebody got them with a lawnmower. They're short, they don't function well, they don't beat. There's big areas that are just completely denuded, where again, you can end up having secondary infection because organisms can set up house because the mucociliary escalator no longer works. So this can be really a big problem. Smoking certainly doesn't help because smoking also kills the cilia and prevents the ciliary function and the beating that we need in order to have our mucociliary escalator work well. So cardiac complications of influenza, congestive heart failure, infection of the pericardium or the myocardium, but the incidence of myocardial infarction is lower when patients are vaccinated. This is a risk ratio of 0.86. It's really quite a good thing for us to be able to tell patients that, yeah, you may still you may still get the flu. Excuse me. You may still get the flu, but you may not be as sick, and this can protect you in from cardiac problems, essentially, if you are vaccinated. So another good reason for influenza vaccine. So the diagnostic tests that we have available right now, there's quite a few. These are the ones that are preferable because they have high sensitivity and specificity. So these are the rapid molecular assays with the viral RNA or nucleic acid detection. They're ready fairly quickly. The PCR and for viral DNA or nucleic acid detection, again, in our hands, we can get it within probably a couple of hours, but it might take up to 8 hours for this. But again, high sensitivity and specificity. So they're desirable tests to have. And a word on vaccines for influenza, there's new recommendations. A lot of this has changed. So the antigenic composition, of course, has been updated because we have a completely different flu now than we did last year or the year before. And before, we were always very, very cognizant of egg allergy, and we were very concerned about anybody that had egg allergy to get the pneumococcal vaccine, the influenza vaccine. But now this is no longer a thing. So egg allergy alone no longer requires additional safety measures. So people will say, go ahead, and if an egg based vaccine is all that's available, go right ahead. We now have exclusively quadrivalent vaccines, and also for good reason. Right now, we've got several inactivated influenza vaccines available, one live attenuated influenza vaccine, and one recombinant vaccine available. And this is what we are vaccinating against. So this is the quadrivalent strategy, because now they do 2 influenza A's and 2 influenza B's in all kinds of the vaccines here. So these are the ones that we think are coming. So these, of course, are a little different than what we had last year, but they try to target this as best as they can, trying to see what is coming a few months ahead of time. So we have here the Fluzone and the fluad quadrivalents. These are the ones that are recommended for anybody 65 years or older. Very effective. And there's Other vaccines, of course, available for other age groups for the recommendations. The recommendations are available. They are altered fairly frequently, depending on what the CDC finds. So here's the data that just came out a couple of days ago from, we don't have enough data for our current vaccine, but we do have recombinant influenza vaccine information, which is brand new, which is more effective than the inactivated vaccine in preventing influenza in adults 65 years and older. So if one has a choice, one should use a recombinant influenza vaccine rather than the inactivated vaccine. So they don't quite know yet if that holds true for patients younger than 65, but these are the ones that are recommended. So the effectiveness is pretty much 40s, 50s, the occasional 60. Last year hit 54. It's percent. It's thought that right now we're possibly in the low 60s, but it's going to take some time, additional time to tell. Antiviral therapy, the timing of treatment should be really pretty quick, preferably within 48 hours of the symptom onset. But if somebody presents and they're at high risk and it's the symptoms have been present for more than a couple of days, it's still worthwhile to treat them. The information for antiviral drugs this year has changed from last year. Oseltamivir, Tamiflu, is still, of course, our choice. The efficacy overall is symptom reduction for approximately 24 hours. It is FDA approved for early treatment in all people. The American Academy of Pediatrics also changed their recommendations, where they're now saying, rather than no, you can't do it, they're saying 14 days or older. FDA says anybody. This may be used in pregnancy. Side effects are not tremendous, just perhaps a bit of nausea, the occasional nausea and vomiting, and it has better efficacy against influenza A as compared with influenza B. Peramivir is another agent. It's only intravenous, and it's for people that simply cannot tolerate oseltamivir. There are quite a few side effects, including erythema multiforme and Stevens-Johnson syndrome. The other two drugs, zanamivir and baloxavir, were on last year's list. They no longer are because there's insufficient data, and zanamivir is only available in the UK and the European Union and has quite a bit of potential morbidity associated with it. So who should receive antiviral treatment? Well, people coming into the hospital with viral pneumonia, certainly, with influenza A pneumonia, confirmed or suspected influenza, progressive illness, outpatients at higher risk, and then again, adults 65 years or greater should be treated. And pregnant women, and also the women who are within 2 weeks of the postpartum period, they should certainly be treated because of the higher risk. Lower risk outpatients presenting very early, why not? If you can decrease their misery by a day or so, they'll thank you for it. Symptomatic outpatients living in households with immunocompromised people, absolutely. And then us, symptomatic healthcare providers whose patients are high risk, and we're essentially at high risk because we are very frequently exposed to these patients. So we should have a low threshold for treatment for ourselves as well. There is this live resource from the CDC on influenza. There's live resources for pretty much all the viruses we're going to discuss, but this is worth looking at because they update this very frequently with information as it comes in. Here is our other little friend, respiratory syncytial virus. We have been having a lot of RSV in our hospital. I don't know if about the Seattle VA, but we've admitted a lot of patients who are quite sick with RSV, unfortunately. It's very contagious and it's seasonal. We are in the peak season right now, January and February. Of course, it's May to September in the Southern Hemisphere, and in the tropics, it's associated with the rainy season. Here's the data to the present. We can see here, this is in 2022, and we can see some activity over here in 2023, quite a bit, and then it died on down and started coming up again in August. And we are now having a pretty good spike. This is present data at the very end of 2023. I think that's December 30th. The data is going to come out again next week to let us know how we're doing with RSV over this past 3 weeks of January. It's the most common cause of lower respiratory infection in young kids, second highest cause of death from infection in infants. Almost all children have been infected by age 2, but look at the mortality in children, about 7%. And a few years ago, we had an adult over at one of our local hospitals, an immunocompetent adult in his early 40s, that was ended up on a ventilator with RSV. And everybody was really surprised because this is an adult now, where adults, generally, this was a child disease, not an adult disease. But not anymore. Now there's increasing symptomatic disease in adults. And because we initially didn't have the index of suspicion, we do now. We've learned our lesson, but the diagnosis was often missed. And there can be a genetic component, possibly similar to COVID, where a person is more apt to get severe disease. And look at the overall mortality in adults greater than 50 years. Very similar to that in kids, even a little bit higher. So this paper just came out, and one of the things that we all always had thought, well, a lot of kids had gotten a viral disease. Perhaps RSV was not diagnosed, but then they developed asthma. So something happened with RSV, and here's a paper that just it has not yet come out in the journal. It was just released as a preprint on December 22nd, right before Christmas. And now we can see that RSV can affect the nerve cells and enter the spinal cord, and it can also cause abnormalities in the nerves that go to the smooth muscle, and that may be the origin of asthma after an RSV infection. So this is hot off the press. They're going to be looking at this quite a bit more. Everybody's very interested in this because RSV seems to leave a bit of a nasty footprint. And this is something that we have to be aware of, especially now that we're getting so much RSV in adults. So the diagnosis is made by bronchoscopy or by nasal swab. The results can be ready and really pretty quickly with a rapid antigen tests, but our highest sensitivity is a PCR, and we can get the results actually quite quickly. In our hospital, we are getting them at about 2 to 3 hours. And this is something that's quite useful to us because we certainly have been seeing positivity. The transmission can be direct and indirect, and it can live for many hours on hands, which is why hand washing is important, as well as surfaces. And again, large droplet aerosols. So many different ways to get infected, highly contagious. The incubation is 4 to 6 days. And again, viral shedding lasts a little bit over a week, and longer in kids and longer in patients with HIV or other viral diseases that are concurrent. We unfortunately have had concurrence with COVID and RSV, or influenza and RSV, RSV plus pneumococcus. We've seen a lot of combinations of RSV with stuff this year, and the patients really, as I said before, are quite ill. So lower respiratory infections, it affects several different points in the lung. Here's the bronchi, the tracheobronchial tree. And then we have actual parenchymal infection with pneumonia. So this can get a lot of the sites within the lung. There is a vaccine. The vaccine is brand new. It was approved by the FDA just earlier in 2023. And it was approved for persons that are at least 60 years of age and for pregnant women. And so the vaccines interfere with the viral fusion protein F, because RSV uses it as a docking station to enter human cells. So if antibodies are made specifically this viral F protein, then it's been quite effective at blocking infection. We're hoping that this pans out, and we're hoping that there's no mutations that get in the way of this. But the RSV vaccine is now being certainly recommended highly to our patients. And the efficacy is really quite good. This is a paper from the New England Journal showing that both RSV A and B subtypes, we have quite a bit of protection with 80 to 85% decrease in clinical disease. So treatment, the strategy has also changed. People used to do ribavirin, which is highly toxic, and you'd have to be in a PAPR and have to have a room that was completely isolated because you couldn't have the stuff getting out for other people to inhale. They don't do that much anymore, and if they do, they'll mix it with immune globulin, and if they use it, it's going to be for very severely ill immunocompromised patients. For anybody else, immunocompetent patients, it's only supportive. So back to our patients. So rapid testing for COVID was positive. Testing for RSV and influenza A and B was overall negative, and so the patient had COVID, just like many of the people that lived with him had. Unfortunately, he developed very severe COVID, and he got hypoxemic respiratory failure. He was transferred to the ICU due to increased oxygen requirements. And then his hospital course was complicated by the thing we hate most, which is the thrombotic complications of COVID. He got a DVT, subsequent PE, severe hypoxemia with that, and had a non-STEMI. To our surprise, he has held in there. He's still alive. We're hoping he makes this through. We're trying everything. He is mentally competent. He has a good quality of life. We certainly want to help this poor patient. So here is our last virus that we're going to discuss. And first, COVID. How are we doing at this point? So here's the data from the CDC that is most recent as of January 6th. And we can see back in 2020, we had all sorts of spikes and valleys. Here's 22 with a Delta, some more surges here. Our numbers are going up. Our numbers in Idaho, as I had shown on the prior map, are certainly going up. So we're a little concerned about that. The only thing that is a little bit more reassuring is that we don't have nearly as much death as we did before. So the death toll for this is not zero, but the mortality is certainly not as high. So we have a lot of cases throughout the world, but the thing that I found interesting is that we no longer report anything for the world anymore. So we used to keep numbers for different countries. We no longer do. And we hope that the US continues to look at data for the states, but again, it's all going to depend on reporting, and it's going to depend on their backlog, etc. So we have here several variants. Of course, now we're in the Omicron family, and we know that the infectivity of Omicron is possibly even more at this point than 9 to 12 times the original strain. It's probably more in the 20s at this point for these different Omicron strains. And so the subvariant that we have right now is JN1. JN1 was less than 5% around Thanksgiving. JN1 is now, I wrote this slide a few days ago, it was 62% then as of January 5th. It's now in the 70s. And it's also the dominant variant in Europe, and it's going up in Asia as well. Well, it spreads just like pretty much any other virus in the air by direct contact, but the respiratory droplets, the smaller they are, the more they penetrate inside the lung and can set up house and cause pretty severe pneumonia. COVID itself, we think of acute COVID as like two diseases rather than just one, because we have the phase of viral replication. We're going to treat that with antivirals. And then we have the inflammatory response that we're going to treat with agents to decrease inflammation. And we do that with different agents in terms of interrupters of the cytokine cascade, steroids. But unfortunately, COVID is not just one disease, as it turns out. It affects just about everything that we can think of. All of our systems, including the lungs, the heart, the brain, the endocrine system now, as we found out, the GI system, the kidneys, you name it. There's all sorts of issues that can happen with the heart, from direct cardiomyocyte injury to pericardial inflammation to ischemic disease. We can get actual MIs. We can get different conduction abnormalities. And then there's scar formation that can cause a lot of future problems with arrhythmias. And a lot of these patients have actually, unfortunately, had to have cardiac devices or pacemakers or both. So lung destruction can be extreme, as we know. PE, just like our patient had. This is actually a representative. This is not our patient that I presented, but this is a very similar CTPA that he had, that this patient had. That's quite similar to ours because he had a very large clot burden. And now the situation with long COVID, the persistence of symptoms or development of sequelae between 3 to 4 weeks, because COVID has not been isolated after 3 weeks. And so here we have the situation where patients get acute COVID. Then after week 4, there's subacute or ongoing COVID with different kinds of systems that are involved. And then by this point, of course, the patients are negative, but now we end up getting chronic COVID, which can be quite devastating. And a lot of people now have a lot of disability because of this. The cardiovascular complications I mentioned before, going to arrhythmias and cardiac fibrosis, and this problem with acute brain dysfunction, the so-called brain fog, which can be really quite severe. And we found that delirium in the ICU has gone up with COVID. And Wes Ely, who has done a lot of the work on ICU-related delirium, has been looking at a lot of patients in, he has an N of 70 ICUs around the world, so different countries. And the highest predictors of COVID-induced delirium were increased benzodiazepine use and decreased family presence. And with our ABCDEF bundle, family engagement and empowerment is one of the things that is absolutely necessary. And the people that could not have their families with them, and the best they could do is just have us on an iPad with them, with a family member on the other end, this really took its toll. What can we do with these patients? There's multidisciplinary approaches with cardiopulmonary rehab was recommended heavily to everybody, but now the question is, we do not know if this is truly something that's going to help us. Because here's another bad news. Now we have actual muscle abnormalities where the extraction of oxygen of the muscle layer can be much worse in long COVID. And so maybe exercise is detrimental in some of these patients. So keep your eyes open on this one, because this can be a really significant problem. Lung transplant is something that I've actually sent several patients myself for lung transplant after having had ARDS from COVID, and these patients did not get back even anywhere near where they could be functional. Lung transplants have been found to be quite useful, but the procedures are technically challenging. There's a lot of pleural adhesions, a lot of transfusion requirements because they bleed because of the scars. But the pathology of the explanted lung showed extensive ongoing lung injury with features of lung fibrosis, but there was no recurrence of COVID in the allografts, and patients tended to do really quite well with the same kind of benefit as that's similar to patients that had transplants for other reasons than COVID. This is a patient in Milan, Italy. After 266 days in the ICU, he could not get off of ECMO. This patient was a professional tennis player and got very severe COVID and ended up having a double lung transplant. And this is him at hospital discharge. The surgeon is on his left, on the left side of the picture, and the hospital administrator, of course, on the right. And this was in the newspapers, and the patient now is actually trying to get back to the tennis court. So he was a very huge success story. These guidelines here for COVID from the NIH, these are live guidelines. They change as data comes in. So I refer to these very frequently as to what is recommended for COVID treatment, what is recommended for COVID diagnosis these days, and how shall we manage these patients, and how shall we manage long COVID. So the data is emerging, and we will hopefully get to the bottom of this once we figure out exactly what now COVID does at the muscle layer because of this new finding of abnormalities with muscle oxygen extraction, which is kind of disastrous. So hopefully in a few months, we'll have a little bit more information. There's a lot of ongoing research. So this gives us still a little bit of time before the session is over for questions for either Dr. Gupta or for me. Excuse me. And we will welcome any questions that you have. The other thing, Barb, that you could consider doing for the audience is if they would like to, if they have questions that aren't answered during the session, please feel free to give them my email and or send us the chat, or we can certainly answer these offline as well. And thank you for your attention.
That sounds great. Thank you so much. Really, I can't tell you what great presentations these were. Interactive, up to date, the latest and the greatest. So I really appreciate it. I did have a question that came up when you were talking about influenza, and you had mentioned that Native Americans, Alaska Natives, are more at risk for complications, and a question about if you know what's behind that.
Genetics.
Okay.
It appears to be a genetic determinant, and it appears that because we've got really good data with RSV with patients that are genetically more prone for worse disease. There's a genetic component for patients that get COVID infections and severity of illness, and the same thing with influenza. And so people can be genetically predisposed, and these might be people that don't have the other comorbidities on that list. They may not have obesity. They may not have pre-existing lung disease. They may be younger. Sorry, I'm losing my voice here. I guess I'm a really good example of a viral infection here for this talk. But that it appears to be genetically determined for that population.
Another question that came up had to do with the discussion about long COVID, and Nancy had read an article that long COVID is more prevalent in the US. Is that consistent with data that you've seen, and thoughts about that?
Long COVID is better documented in the US as compared to some of the other countries because the US caught on to this, thankfully, fairly early. We were probably, at the University of Washington, I have to say, was one of the leaders with this, with trying to get these long COVID clinics started, these long COVID programs. And they did this fairly early before other places were doing this. So they started gathering data very, very early. The suspicion is that if you have all takers, or I should say all comers, that long COVID would be an equivalent kind of prevalence in other places, but the numbers may not be there. I showed you the world map and the fact that now nobody is counting anything. That to me is a little disturbing. But again, we also realize that people may not be presenting or testing or reporting the testing, but I would hope that the long COVID patients would be a registry of some sort would be made for people in different countries, and that we would pay attention to those. Nancy's right, though, because in some countries, it's just kind of been accepted that people got COVID and they have these secondary problems with these disabilities, and there's not too many questions asked. Here, there's a lot of research, which I'm happy to see, as to how to best treat these people. We used to think exercise was fabulous, and it probably still is for the majority of people. But now with the situation where oxygen extraction is impaired, and we found that, this is very analogous to, excuse me, to chronic fatigue syndrome, where you might exercise one day and be absolutely incapacitated for days afterwards. It appears that COVID may be doing that to some people as well. So that's kind of a long-winded answer, Nancy, sorry.
Oh, that's helpful. Elizabeth was also asking, does the muscle oxygen issue with exercise cause tissue damage?
Very good question. They're now doing some muscle biopsies to try to establish that, and they have seen some abnormalities in the myofibrils. They don't know, because what they've actually done is exercise some of these patients and gotten a muscle biopsy after exercise, and there's an inflammatory response. Now that's a problem. So we don't know if that's going to lead to muscle fibrosis or impairment in oxygen uptake. That's permanent. What they're hoping to do, and we don't have much information on this yet, is to obtain the muscle after exercise and then obtain the muscle after rest and see if that starts to come back, because we don't know if some of these changes are irreversible.
So Erin is wondering about the timing of vaccination for influenza, hearing about people not wanting to get it too early in the fall, just in case it's not effective later on.
Yeah, I think we've all been through that. It's really a bit of an epidemiologic answer. And what we do, at least what we do here in the state of Idaho, we have an epidemiologist who keeps us all apprised when the numbers are rising, because there's even some people who get 2 vaccines, one very early and one later in the year. And I know a lot of people who do that. I don't think, and I don't know, Supaksh, if you know, but I haven't seen data showing us that that's an effective strategy. But one of the things that has been found in some places to be quite valid is get the vaccine. Get the vaccine when it first comes out, because the vaccine is not going to protect you immediately. It's going to take 10 days, 2 weeks or so to get the to get the immune response up and running to be protective. What the recommendation is being made, and it hasn't quite gotten into practice, but we're hoping someday it will, is to do a check kind of a few weeks into the season. Is our vaccine, is what we are targeting, is it effective? And is it protective enough? Should we change strategies and redo the vaccine maybe early in the following year? So that you end up having something that might be 2 vaccines with different determinants within one season. That's something that people are looking at. I encourage people that, get the vaccine when it's available and when your particular area, when the numbers start to go up. In some places, we don't have much of a choice. I don't know about some of the places where you folks work, but with us, we had to have it all done by October 30th, which is actually fairly early in the season. Some of the private hospitals, it was November 30th, but we're also kind of held to compliance within a certain timeline. So I do recommend that patients at least get it fairly reasonably on in the season, at least October. Don't wait till December or January, because by then the numbers might be quite high. The other thing we don't want is it has been found that if you get one virus, you're kind of a sitting duck for virus number 2, which is why we're seeing so much comorbid or co-infection, I should say, with some of our patients that have COVID and RSV, or COVID and influenza. And we don't like that. So, and these patients may even have been vaccinated. And so one virus is going to weaken you and make you kind of a sitting duck for another one.
Interesting. Yeah, I can see that. This is a question for Dr. Gupta. Is there any evidence for the best type of this interesting question for the best type of physical activity to prevent pneumonia, like strengthening or effective cough or aerobic exercise?
Yeah, that's an excellent question. I think, in general, what I tell patients, I think aerobic exercise is probably the most effective in terms of overall health, as well as kind of was alluding to earlier, with exercise, you get airway clearance. And so patients sometimes with lung disease will notice that after they go for a walk or a run, that they'll cough up a lot of sputum afterwards. So, all exercise is important. I think another thing that's really important is muscle mass in general, and we lose muscle mass as we age. And so strength training is also really important. But I think for overall health, the first thing that I tell patients to focus on is kind of aerobic exercise. But once they kind of build that into a routine, trying to build in a little bit of strength training is also really important.
Very helpful. I'm going to ask one question that I've been thinking about, because I hear a lot of people as they're wondering what's going on and thinking it might be pneumonia. And so they're trying to make decisions about whether they should seek healthcare or not. And in the days following COVID, people are starting to measure their own oxygen saturation and think about coughing and that. What are some things that you would like to see people coming in to get assessed for, as opposed to hanging in at home thinking about it, to avoid pneumonia getting worse?
Yeah, I think, kind of as I was alluding to in the population that we're all talking about, adults over the age of 65, the risk of severe disease is higher. And so my recommendation really is to, if you are having symptoms, to get screened earlier. So as Dr. Carvalho showed, there's a lot of therapies available for not just bacterial pneumonia, but viruses, right? So you can reduce the symptom burden of influenza by a day. For COVID, we now have antivirals that we can treat people with to reduce the severity of disease, reduce the length of disease. So it actually is really important to get screened for these things because we have therapies available to help. And a lot of these things have been shown to be helpful early on. And so, the best way to prevent pneumonia or bacterial pneumonia right now is to avoid getting a virus. So, masking, social distancing, things like that. But then if you have a viral infection, to try to treat that early on, because there's a lot of comorbid viruses and there's a lot of comorbid virus plus bacterial pneumonia. So I think it's always worth to get tested. And then if you get tested and know that you have a virus, you can make sure to isolate yourself to make sure that you're not spreading that to other people in your family or community.
Okay, one last question. Dr. Gupta, you'd mentioned tobacco smoking. Do you have any experience about people who might quit smoking but start vaping and feeling like it's safer?
Yeah, that's something that's still we're learning a lot about. I think probably, from the data that we have, vaping is probably not quite as dangerous from a number of risk factors as smoking cigarettes is, but both are not recommended. And so, it could be considered as a lesser of two evils, but really I strongly recommend patients kind of quitting entirely, because they might just replace sort of one habit with another that's maybe not quite as bad, but still can put them at higher risk of all these things. And vaping is going to impact your cilia, as Dr. Carvalho showed, and all these other things. So there's still a lot of adverse effects, but the risk of cancer and things like that may not be as great. But it's still so early that we don't really quite have the data on a longitudinal scale to kind of say those things more definitively.
And it actually may be my lack of knowledge, but I guess I've assumed we don't see vaping a lot in older adults. Do you see those in older adults coming in?
I see it a fair amount. Not quite as much as in the younger populations, but yeah, like you mentioned, there's a lot of patients that were addicted to cigarettes and then sort of transitioned to that. So it is definitely less than the younger population, but it's definitely still there.
Interesting. Well, Drs. Gupta and Carvalho, thank you so much for these presentations. I appreciate you staying a little bit over to answer questions. And everyone, the videos, the recording should be posted within about 24 to 48 hours. And so tell your friends and colleagues about it, because this has just been some invaluable information. Thank you so much.
Thank you for inviting us.
Yeah,
Yep.
stay safe and warm out there.
Thank you.
Thank you so much.
Bye-bye.
Bye-bye.